different tumor.
Yeah, no.
Yep.
That's my brain talking about right there.
See what-
Did try to reach Dr. Bremner again, but he's been out this week. Um, and he kind of told you that he felt that it was not really going to be resectable, right?
Yeah, he said that it was kind of, the pictures he showed me that it had grown into the aorta.
Yeah, what was these pictures here?
And he said at this time. I don't know if that means he can do it later or.
I'm not gonna be back and then I can take notes.
So I know that he mentioned that this was at least right up to the aorta there, but that he kind of at least thought it was attached to the aorta, I think. And,
Right.
And then also this lymph node that he biopsied, this
Right
pre-aortic
here, I
lymph
think,
node,
somewhere in my chest area.
right, was also positive for cancer.
But the trachea wasn't, oh, that was fine, he said. He must-
Right, but there was a pre-aortic node, which is also kind of in that
So there's
middle
two?
of your chest.
Yeah, this one I know about, because
Area.
this is where it hurts. I'm figuring that's where it's at, 'cause it hurts right around there.
Well, and some of that is certainly the disease.
And him poking around probably right around there too.
And certainly if it's invading the aorta, this would make this, I guess, at least potentially that way, a stage 3B lung cancer. And I know, when I talked to him, he kind of mentioned that he felt surgery would not be one, very easy to do, and because of the extent of it and growing into the aorta or around the major blood vessels, and that if one were going to even attempt surgery, it probably require removing the whole lung,
Right.
which was also a concern, especially in view of the fact that it's already spread outside of the lung into the brain, and felt that that would be a lot to, I guess, try to do in view of the fact that it's already spread.
Mm-hmm.
Okay. And I know so we've talked about either kind of definitive surgery, radiation,
Mm-hmm.
using that to treat the disease by itself, or I guess the alternative of whether one would attempt preoperative chemotherapy or chemotherapy and radiation to see if we could even shrink things down enough that he could attempt surgery. And again, he's out this week, so I wasn't able to ask him about that. first of the year, and when he should be back, and I can at least ask him how he feels about that. But it's seeming to me that he thinks that probably the best approach is just to do definitive chemotherapy and radiation, and that there's not a high likelihood of him attempting surgery, was my impression.
That's from more
That's what he told us.
Yeah, that they wouldn't be able to, so that's what my whole thing is what is radiation and chemo gonna do for me? Anything?
Well, when disease is more locally advanced, certainly chemotherapy and radiation is the method that we would use to treat somebody. Is that we know that even with treatment, there can still be a fairly high risk of recurrence over time. But we would use a standard kind of aggressive approach, chemotherapy, radiation, to try to I guess, get rid of the disease. And probably if you look at studies, one common regimen we use is something called Taxol carboplatinum, and giving that along with radiation, where somebody gets weekly chemotherapy during radiation. And radiation goes on for probably close to 7 weeks. And sometimes I've given a couple higher doses of chemotherapy afterwards than what we can give with radiation. And use that as a method of treatment. If you look at probably stage 3s altogether, that type of approach can probably give average survivals of around, I would say, 20 months or so. Realizing your situation's a little different in the sense that it's already spread.
Yeah, cause it could be quicker because it's already gone up to that area.
But we don't know about anything anywhere else.
Yeah, that's my question.
Okay, so at least, and this has been resected and removed, so we know, again, you're still at a higher risk for things elsewhere just because of it already traveled there, but we haven't found that.
Right.
This has been removed, and so it still makes sense to me to treat this aggressively because we don't know of it being anywhere else, and give you the best chance we can as far as helping to control the disease.
Well, could you do chemotherapy? I fully understand that because there's micro cells in there that, you know, we've only detected, what, 3 places for the cancer, which is odd in itself with a PET scan. So my question to you would be, we start with radiation and you kill, you know, what's in our body, and then it shrinks with radiation, or chemotherapy. Try chemotherapy, I guess, would be first.
No.
Instead of the two together, is there a plus and a minus to doing it together?
Well, if we're trying to control the disease in the chest, both therapies together
Are gonna make it.
give us a better chance as far as controlling the local disease versus using radiation alone, and certainly versus using chemotherapy alone.
Okay, because I was thinking it would shrink it then with chemotherapy, and then they could possibly
Radiation would
do
shrink it
something.
better.
Well, radiation would probably shrink
Shrink it
it, but
more.
the chemo would treat the whole body.
Body.
Yeah, that's what
For
EMF did, right?
chemotherapy treats the whole body, plus it also helps sensitize the local tissue to the radiation to make the radiation more effective.
So it really needs to be in combination then, in
So
her
the best
case.
approach is combined therapy.
Yeah.
What about biomarkers on, for the chemo treatment? Because we read about Caris Life Sciences.
And I think
You're on it. No, you're Ironwood is on it.
I mean, I don't know if this type of cancer falls under what they do, or if it makes sense, or if even insurance pays for it, and if not, what it costs.
You know what, I'll have to,
Because I know they talked about it in '94, was just coming on board where we live. So it's been out a while.
were certain things that,
Yeah, what I got out of it is there's certain things they did and certain things they didn't on, with biomarkers.
and what I would,
And if so, would that be a benefit for her?
we pretty routinely, when we have a sample, send it for, testing for, different things to see if the tumor would be sensitive to that.
And Dr. Bremer said he had a lot of specimens. You know, he's got these good.
And I don't think I had that from, California. Let me see.
Yeah, yeah.
On the brain?
I have. What does he need?
We have the pathologies from
California.
California if you need it.
Yeah, what tells you?
I got it
think
here.
Oh, yeah, you have
He
it.
has it. I gave him the
So
CD.
much stuff to input.
Okay, so they sent it for this EGFR mutation,
Yeah, right here.
and,
If I remember right, it was negative, but I'm not sure.
and then there's also, elk, test that we sent it for to, and that is something I might need to ask, Dr. Bremner to send for,
He said there was plenty of specimens to do that.
To work with, yeah.
because we would normally send it out for the same panel of, markers to see if there's, a certain mutation there that a certain drug would work for.
Mhm.
I'm not seeing that here, but now that we have tissue, we can ask, Dr. Bremner to send that
Yeah,
off.
he's got it to show up where it matters. which
That,
is
yeah,
the
make it feel a lot more comfortable.
And,
know that
so
exactly.
those are things that we would do, yes. And
So that's a
was-
normal procedure for
That's
Detect
pretty
it.
much normal procedure when
Okay,
we, diagnose lung cancers, to send it for these different markers to see, you know, if there's changes there that are going to make, as part of the overall treatment, one drug, the cancer susceptible to certain drugs that we would
Right.
want to use.
What about as far as, I know there's no surgery, but what about something like gamma knife? Something like that to, I mean, I don't really understand it other than it's like a radiologic type of surgery where it goes in and destroys,
You
lung
know, I
or
think
tumor tissue.
in this case, it would be more standard external radiation because you're going to have to cover this whole area,
Mhm.
lymph nodes, tumor, and
Right.
more so than a focal.
Yeah, gamma would be more precision rather
Yeah.
than the area.
You know, of course, the radiation is pinpointed to this area, but it's going to be a bigger field because we have to encompass the tumor and
Yeah.
the lymph nodes and everything. Gamma knife is more focal radiation for smaller lesions.
Okay.
Like if we have an isolated spot in the lung and we're, maybe another cancer's left a little focus in the lung and we're trying to pinpoint that, we can do a smaller area of
Okay.
focal radiation. This we need kind of a more
Yeah,
wide
more
approach to
broad
cover
area.
all of that.
That makes sense.
So, little different than gamma knife, which would be more focal for a smaller
Right.
area.
Yeah, the thing that confuses me, but that's life. You know, they found it in her head, found she had lung cancer, PET scan, okay, except for that. He did the exploratory, found one with cancer, but in all the reports, it must be microscopic cells we're looking at, because
They
I
found
don't
it in
see
the
anywhere.
PET, they found it in the PET scan.
Well, no, the
Yeah.
PET scan, of course,
It
showed it, so
showed
that's
it.
not
It showed.
microscopic cells, that's
Right.
certainly.
The PET scan showed it.
No, it showed this,
Yes.
yeah.
Right,
But
but
I
it's
mean-
not showing anything anywhere
Yeah,
else, so
right.
that's
It wasn't
one,
good.
that's a very good thing, and
Yeah.
we're fortunate because of that. But we know that we're at risk for that
because of-
that's
because
right.
it's already
Absolutely.
spread there.
Right.
And even a PET scan is not gonna show us microscopic disease.
Right, I understand that, yeah.
Okay,
So basically, the chemo's to cover everything if,
chemo will go throughout the body.
yeah,
And it will help treat this, but by itself, it's not gonna be
Because
sufficient
it's gotta
to
be the radiation.
treat this, so you need radiation for the local disease. And again, the chemotherapy helps sensitize the tissue to the radiation to help make it more effective.
okay. Okay, yeah, it just
That's
blew me
why,
away that it was only there, I guess.
That's,
That you were able to see, not,
well, and again, it's a blessing that we only found it in one area, and sometimes we'll see that with lung cancer, and that's one reason why we wanted to certainly explore the option of surgery, because there have been long-term survivals with isolated brain lesion, and if you're able to eradicate the local disease. Now, surgery, yes, we would have liked to been able to do, but it seems realistically like that's not going to be possible. And so certainly we want to hit it though with chemotherapy and radiation to give us our best chance as trying to, you know, eradicate this. Is there going to be certainly a risk of not being able to do that or having disease show up? Yes,
always.
but we want to give it the best shot we can.
So it would be chemo, it would be like once a week chemo and then radiation every day, or radiation every other day?
Radiation every day during the week,
Because I'm
and
doing,
chemotherapy weekly.
today's my last radiation for my head.
Okay.
How,
and
go ahead, sorry.
and that's what Dr.
Oh, no.
Oh, no, okay. And so what we would do is have him start doing measurements for the chest, and it would probably take a week to get all the computer mapping and everything that they need to do, and then we would go ahead and get started. Now, if it was going to take, depending on when he was going to be able to get started, we could even do start a weekly dose of chemotherapy ahead of time too, but and then plan to give everything, you know,
On
weekly
back.
still during the
That's 7 weeks.
radiation.
7 weeks of radiation, how many weeks of chemo, do you know?
Well, we would get her every week during the radiation, and then sometimes even give a couple doses afterwards at a
So,
higher
up to 10?
dose. I would say roughly, yes.
So our radiation treatments are at the other facility. Is chemo done here? Okay, so it should be between the two facilities.
Okay, yeah.
Okay.
And the, what is it, an IV drip? I know they have pills and everything else now, and they
This
have a
would be-
buckle you could, you know,
This would
attach it.
be intravenous chemotherapy.
Can you do it with the belt though, where they have automatically give it to her so many times each day, you know?
No, it would be coming in here,
Okay.
and it's going to take roughly, I would say,
Now, how many hours?
4 hours
Per
on
visit?
the days that you come in for the chemotherapy.
Okay, did you have any more questions, Steve?
I think that's pretty much covered it. I mean,
Now, what would you do if your family members, what I wanna know?
Well, this is what I would do.
You would definitely do this.
well,
And,
the only question the only question I did have about the biomarkers, how long does that take to get sent out and get the results back? Because
Yeah.
really to start chemo, you have to have all that information.
Well,
right?
no, because I think this initial approach would be the way we would proceed. Okay, now those markers, you know, may have a role as we go along, but I think this would be a way to proceed.
So like a sort of like a generic sort of
yeah, and
A
chemo
common
for that
initial
type of
approach
cancer.
that we would do. Yes.
Okay. And then
even Dr. Berger
if it
said-
warrants, then you put the other chemo in later
Yes.
when you have it.
Okay, yeah, because
That makes sense.
Dr. Brimmer, when I brought it up, because I knew they'd been testing it since '94, but, you know, not everyone's in the same situation, body-wise, physically.
Well,
And that's why I like the idea of having chemotherapy tested against the tumor and then working around that.
well,
And
as
that
far as, you know, testing the drugs to specific chemotherapy drugs, that's been done for years and
Mhm,
years. And it's never really caught on because what happens in the test tube doesn't necessarily always equal what happens in the body. And so we still use the most active drugs we have in lung cancer and use those for patients versus necessarily what the chemotherapy sensitivity test might tell us. Other than the fact that there are special drugs that could be effective if there's certain, again, mutations and things that are present. So it would be looking for, is there going to be a role for other type of therapies to use in addition to what we would take as a kind of a standard approach.
Yeah, because, well, I guess I'm crazy. But, you know, if you can match the tumor to one of the chemos, to me that makes common sense.
Well, it does, but like you said,
You know.
in the test tube's different
What
than
about
what's in
those
the
people
body.
who are using this?
And you know, Avastin.
Believe me, I'm searching all over.
Avastin has
Good.
been used.
I was gonna ask which one you would start with.
No,
With
If you know that.
I'd love to start with it.
like with people who have had metastatic disease and adding that to carboplatin and the Taxol. I guess I would have to check with the addition of radiation. This would be more in the setting when you have metastatic disease and not really trying to just treat local disease. That can be considered. There's another drug called Alimta that will sometimes do for adenocarcinomas, and I'm trying to decide what they.
Appreciate your help because I'm searching all over for it.
I know that was mentioned somewhere in all these reports, the adenocarcinoma.
Yeah.
The final. Findings most consistent with poorly differentiated adenocarcinoma, because sometimes there's a variation of a drug called Alimta with either cisplatin or carboplatin, with Alimta having a role in more adenocarcinomas. And so sometimes that can be a consideration also, trying to.
So really, when somebody speaks of chemo, it could be a whole different combination of drugs, not just
Well, there
one.
can. There are trying to break it down more if there's a certain type of histology. And with the adenocarcinomas, there's a drug called Alimta that can.
Yeah, I think you guys listed some of the brochures.
Be
here.
considered, and I'm not, because one area it says here favors squamous carcinoma, and then in another report there they mention possible adenocarcinoma, and I might need to confirm that with the pathologist and see if they're able to distinguish for sure.
That was a little
Because
confusing
Yeah,
to me.
that was Cedars had that too. That's probably what you're looking at. Yeah, and it was.
Brain.
Well, no, this is the one
Yes.
from,
Yeah,
because
it's-
both are mentioned, although the adenocarcinoma is mentioned in an addendum, and maybe I'll need to try to confirm that with them and see if they're leaning one way or the other for sure. Because sometimes that will influence, and I had that as a note to try to check on that, because here they mention possible adeno, and then in another part they say favor squamous, which would be different. The Alimta wouldn't be used for the squamous cancer.
I got the impression it was probably both a little bit, but the way, like,
Well,
you know,
it's just
And I
confusing
think
to
I
us.
might need
Yeah.
to confirm that with them and see if they're leaning one way or the other for sure. Because that, sometimes will vary the combination
of
we'll
the drugs.
use with radiation then, and sometimes with adenocarcinoma we'll go a little bit more with the Alimta. And sometimes with metastatic cancer we even give what's considered maintenance therapy, where we keep people on chemotherapy kind of chronically, and there's been a role for that too. And I suppose even though your situation's a little different in that all the metastatic disease has been removed that we know about, I suppose there could be a consideration whether we would want to even consider that type of an approach, which we do for people with more active disease at different sites. We might give them so much of a combination of chemotherapy and then keep them on a more prolonged chemotherapy with just getting this Alimta drug for adenocarcinomas, as we call kind of a maintenance therapy, and that could be a consideration. But I think right now the initial thing is using the combination approach to try to treat this,
Now, are they gonna do like
see
in
what
the
things
middle,
are like, and then
in the middle of it, will they do like a chest x-ray to see if anything's going on, if anything's happening? Or are we just
Well,
gonna go
it-
all the way through it and
Yeah,
look
yeah.
at?
well, you would normally go all the way through it because it's not like it's something you're necessarily going to see shrink from such a size to real quickly, because it's
Well, I just
more,
wanna make
I
sure
would say,
it hasn't metabolized
That's the scary part.
anywhere else.
right,
That's
because it's
what I'm-
more of a, and you have a point there. And I guess considering when the last PET scan was, if it's been close to 2 months, we could decide if we even wanted to repeat that again before we started.
So I just wanna make sure it hasn't gone into, like, through the chemo, I don't wanna do chemo if I've already got it in somewhere else. If I've got it in my liver, there's no sense in it.
right,
There's just no sense in putting myself through that pain.
that's what I was just gonna ask you about that.
Well, the PET scan was only a month ago,
Yeah,
and
so-
it didn't show that. It's kind of early to.
Yeah. But I'm seeing if we start the treatment and just make sure that it's not going back to my brain or it hasn't gone.
I know a lot of cancer
I
patients,
mean, I don't know if I can get a PET scan down. We could consider a CAT scan again to look at areas as well as
Yeah.
and see while we're waiting to get you set up for the radiation, and the insurance might give us a hard time with another PET scan so soon.
Our PET scan's a lot more expensive than CTs, is that what it is with insurance?
Well, it does cost more, yes, and but I mean, we could try, but.
Well,
give us a
I'm
hard
just saying I
time.
want to go do the treatment, but as we're doing the treatment, I want to
Well,
halfway through check to make sure I have it.
That's
I'm
not
good.
getting worse instead of better.
Right. What?
Yeah,
then I would
a
stop.
lot of
as,
people
as
it
far
does.
as the primary disease, they'll be doing a CAT scan looking at their fields and stuff, and they'll be able to tell you
If it's gone like to my anywhere like.
well, they'll at least be doing that at the
Yeah.
chest, and they'll be able to tell you that things are not getting bigger, and they could tell you if they're seeing any shrinkage or so, because they'll be monitoring their field as they go along.
So there is you will be able to see some shrinkage if it's happening.
Well, yes, they'll be visualizing things. It won't be a dedicated scan to have a report on, but they'll be looking at that as they do the radiation to see if there's any adjustment in their fields and stuff, and they
That's
can at
just
least get a view themselves what's going on with the tumor as they're doing the radiation.
But we don't know because it went from here to here, so we wouldn't know if it was from because we were just gonna do the same area. It could still go from here to my liver.
Right, that's not
or
going to
to my
show.
kidney.
That
That's
would
not show.
require a different type of
Yeah,
scan.
But the
to-
chemo
to
should
look
be
for
able
that.
The
to,
chemo
But
should
you
be
would
able
hope
to.
the chemotherapy
suppress
would be
that.
keeping that from growing or happening.
And basically, I consider it lucky that there's only only three spots. I mean, to me, that's a plus.
Yes, I agree with you.
Then hopefully that will extend her life because, you know,
Yes.
because of it being 3 things. I mean, for her to go through chemo, believe me, I've seen people. Plus,
Well-
you know, I don't know if they have new drugs out. That's why I wanted to go
You know, these,
with the cancer, the markers. I've heard so much from other
you
people.
know, it's all relative. Of course, there's side effects of chemotherapy,
Mhm.
nausea, vomiting. We have pretty good medication to control that in most people. Hair loss, low blood counts, the white count low and
I know they go through it.
infections,
If you don't do treatment 1 week, you,
anemia, low platelet count. Those are cells that'll keep us from bleeding. With this Alimta regimen, if we use a drug called cisplatin, that has more nausea and vomiting associated with it potentially, but again, we have pretty good medications to control that in most people. And then neuropathy, numbness and tingling of the nerves of the hands and feet, that can sometimes happen and be permanent if that develops. And I guess that's one of the bigger issues people experience, but
I think that's why I wanted to have the tumor tested against the different chemos because I've known people, breast cancer, they get the same treatment for the breast cancer, you know. Some die still, some it doesn't work on them, so then they say, well, let's do another round of chemo with this medicine. And oh, that didn't work. Oh, let's try this medicine. You know, and I just don't want to see her go through that.
I'm not going to go through that.
No, I mean,
I already said, I'm
and
going to sit on that.
I know,
we know what the most active drugs
Right.
are. And again, the problem is that what they test in the tube doesn't necessarily correlate with what we're going to see happen in the body. And that's the
Oh.
issue we get into. Just because it worked in the test tube doesn't mean
Well,
it's going to work
yeah,
in the body. And
it's
just because
been
if it
working
didn't
though.
work
Oh,
doesn't mean it's not going to work.
because it started in '94 around there, yeah.
Or even probably older
Probably,
than that.
that, 'cause I considered having it done.
Definitely older. If we heard
Most
about it in
definitely.
'94, it's
So
probably
Yeah.
older than
it's
that.
been going on for a while. But
How long does
nothing
it
we
take to do these markers
Well,
and the cost?
you know, I'll talk with
I'd
Dr.
appreciate it.
Bremner, and it'll be more some
'Cause he
special
agreed with me.
testing that they do.
You know, I just told him everybody's different, you know. And he agreed with me that, you know, if you can get it tested, get it tested.
Well, yeah, like Dr. Kellogg said, that's normal procedure.
procedure, he has to do that anyway.
Okay,
For the
but,
chemo.
okay.
But that's again, it's a little bit testing for more special things
Right.
that we
Right.
can test for nowadays versus actual sensitivity to certain chemotherapy drugs.
Yeah, because I was afraid she'd take the drugs and, well, this isn't working after 10 weeks, so let's try another. And I'm sure you know, you've seen patients that's happened to. It's happened to
We all
everybody
see
here
that
and there.
happen. Mhm.
Everybody's
But-
different, every cancer is different.
You dropped it a while ago.
Oh, thanks.
So,
So, we're gonna talk to Bremner, then we're going to talk to,
what is I would talk with Dr. Oh no.
okay, you're gonna talk to him, okay.
And at least so we can start proceeding with this,
Okay.
because it is going to take a little time to get that set up.
Seems like it's
And,
not growing real fast.
We can go ahead and see about getting another scan or so, and
Well, we just had that
Sure.
chest x-ray, so, I mean, that.
PET scan's more detailed.
Yeah.
right, I mean the scan is certainly more detailed.
CT.
And then we can, and I'll try to talk to Brenda early next week, and we'll check on the any results of what they sent out for. If they did, if not, then we'll make sure it gets sent out for the necessary things we would normally do.
And if there's a
And then it
possibility,
comes
if it shrinks, if there's a surgery, if there's a possibility of that.
Inquire about that, but it doesn't seem
It
It sounds like it'd be the whole
Yeah,
deal,
they
no
go-
matter what.
to really do that regardless from talking to him.
Yeah,
What
just
now?
because, yeah, because of it being,
Just because of how advanced it is locally.
yeah.
So it'd take a lot of shrinking to change that.
Yeah, so there's no possibility of surgery, okay, that's good to know.
So what happens if she does nothing? Besides, she's gonna die.
Well, I think the thing we're gonna get into is this growing around her breathing tube more, and then at
Yeah.
least, before too long, I would envision having more respiratory symptoms, getting more cough, short
Yeah,
of
I'm
breath.
starting to get cough now.
And things like that, and and we can work on trying to manage those, but I think that would be what we're gonna see happen here.
So if it was one of your family members, you would do the chemo.
Yes, I would. Certainly at this point, I would.
Okay.
Certainly at this point, I would, without a doubt.
See how many people die. Sorry.
No, don't be sorry.
Okay, so we will say a week, the talk to Brenner, then we'll take about a week. Yeah, because I've been having a cough at late, like early in the morning and late at night, and it's not real deep either.
It seems like you're moving there all over.
You did a test, you did the, that reading test? I haven't found out the results of that, so, not
When
sure
you're
that.
involved?
Yeah.
Oh, yeah.
Are you just scheduled for radiation only or to see a doctor today?
Radiation.
Only the last.
I only see him the first visit, and then that's it, I don't see him the last one.
I wanted to ask you, you had said 20 months for what, if she had treatment? It would add 20 months to her life, or, you mentioned 20 months.
Oh, yeah, that's right.
I'm sorry.
Well, I
What you said.
would say that's kind of where average survivals would be. Probably if one did nothing, it would be on the order of, it's always hard to say for
Again.
sure, but with metastatic disease in general, it could only be in the 8 to 9 month range.
And have you seen people go in remission after this, where it's just
And I have seen
Spotted.
capo.
just spotted areas? There are
I
on
mean,
here.
I have seen that happen. Have another lady who locally advanced disease. Her disease was gone for years, and she ended up getting a totally different lung cancer. And so that's her initial one has never come back, and so yes, well, we do see that happen, and unfortunately, it's so yes, I would say we can see that happen, but it's more of a minority versus the majority of people.
Well, this cancer is a minority, I think. Wasn't it Brewer that said that? Something that it was an odd cancer.
I think it was,
I think it was only odd because it was only seen in the brain
Yep.
initially.
yeah, it was Matt,
Maybe-
remember that?
Right, maybe just the presentation is, although it is one we see happen.
I need to copy my report back.
What was that?
Oh, okay.
What?
I'll let you have this, and we'll get a copy of that back then.
Okay.
And probably we'll have one of the chemotherapy nurses talk to you, and
Yeah?
yeah,
Okay.
if
That's
if
fine.
you have time for that before you leave.
And then
The big
do I
shop.
see you before I do everything, or?
And we'll probably have something set up, not next week, but the following week to get started, but I'll work that out with Dr. Owen.
Oh, no, Brendan, okay. Okay.
All right.
And I'll definitely check for the markers, too.
Yes. All right. Keep our hope up and
Yeah.
be as aggressive as we can.
So,
I guess I thought we had, we didn't even know about it until it was.
so I'll get that,
Is this yours?
No, that's fine.
You can
No, it's
keep
fine.
that, and yes, I'll have them give you a copy.
and then I'll set up an appointment with you for after chemo, okay.
She
Well,
waits
you-
in here.
Yeah, because I.
No, out there.
Oh, we'll set it up on the way out, yeah.
In the middle of it, nothing's happening, you go off on it and live her life as best she can. Yeah.
Yeah, that's all
Your
Brendan.
success rate, can I ask? Tight, slim to none? No.
Like I say,
Brendan.
About.
overall, because it's already spread, again, there is a pretty high risk of it coming back.
Yeah, sure.
The,
Hopefully the chemo will
Has put
prevent
the
that
foot
for
down.
now.
Yeah, it's fine.
There are a limited, smaller percentage of people,
just the aggressive therapy if nothing's going on, right? And you will get the markers for that one?
Yep, and we'll
Please.
be, giving that.
Okay, thanks.
All right.